associate professor in the Department of Family and Community Medicine at the University of Missouri. She graduated from the University of Missouri School of Medicine in 2009, and residency program she completed in 2012. In 2015, she completed an academic fellowship, earning her a Master's of Science in Public Health degree. Dr. Braddock researched child obesity, especially new technology for families and EHR tools for providers to address child and adolescent obesity in clinic. She cares for patients on her Continuity Family Medicine Clinic, including adults and children with obesity, as well as teaches residents and medical students in the inpatient and outpatient setting. She is also Health Informatics and Diabetes Research, HIDR core member. And we're very happy to see Amy presenting today. So, Amy, the podium is yours. Thanks for coming.
Everybody still see my screen?
Yes, we are.
Okay, perfect. Yes, thank you so much, Dr. Simoes. I am going to be talking about a project today that I've been working on the past couple of years. And this is actually a presentation that we initially planned over a year ago, and it's been delayed 3 times, including last time for a family health emergency. So appreciate everybody's patience to finally watch this talk. I hope that you will agree that it's worth the wait. So we're going to be talking about an mHealth app and EHR tool, CommitFit, to facilitate adolescent health behavior change. So our objectives to get started, I'm going to talk a little bit just about kind of the prevalence and contributors to adolescent obesity and why we care about it clinically. And we're going to talk about mHealth apps and how that can address some of these health behavior changes, and then analyze ideas and leverage gamification and other behavioral techniques with mHealth apps and EHR tools to reduce obesity in adolescents and adult caregivers. So to get started, this is not probably surprising information for a lot of you out there, but we have a huge, significant public health concern with adolescent obesity and child and adult obesity here in the United States. But specifically in adolescents, about 20% of adolescents have obesity, which is about 8.4 million US adolescents. And then 40% have either overweight or obesity. And this contributes to our rising healthcare costs in the United States to the tune of about $14.3 billion per year for adolescent obesity alone. So it's a significant cost, significant problem. And the reason that we care about this from a lifetime of medical concerns is that 90% of adolescents with obesity will continue to have obesity as adults. So we see this as kind of a teachable time period when we can try to address some of these health behaviors to prevent obesity in adults. But as Eduardo mentioned, I'm a family medicine physician, and so I care for adolescents and adults and children with obesity in my clinic. And we know, unfortunately, that we're not serving this population as well as we can, that the clinic-based status quo fails these patients for a number of reasons. There's a lot of barriers that are kind of working against us. We know that our counseling is not as effective as it could be to result in this meaningful health behavior change. And that we really, specifically with this talk, we lack tools, including AHR tools and mHealth tools, to really help adolescents with the motivation and adherence to continue these health behavior changes that is necessary to result in decreased weight. And we also have poor continuity. So some of these patients we may only see in clinic once a year, maybe a couple times a year, and that's just not sufficient to really motivate the change that we need to see. This kind of shows the trends of child and adolescent obesity through the past couple of decades. And we have made great strides, especially with sort of the 2 to 5-year-old, the early childhood range, with some like plateauing and improvements in the past 20 years or so with obesity. But you can see with adolescents, the 12 to 19, that has really just continued to rise. So the effect overall is that all ages have had an increase in obesity. And we know that that increased during COVID, so we're still continuing to work to try to curb those trends. We also know that there's higher rates among low-income families. So children from low-income families are almost twice more likely to have obesity than children from families who are never low income. So you can see on this chart from the NHANES that as you go down and the poverty income ratio decreases, so they have increased poverty, you can see increased rates of obesity in both boys and girls. And you can see how those rates have really increased from 1988 to 1994 to 2005 to 2008 with those green bars. We see significant rises in those low-income families. We also know, this is also not going to be surprising, but obesity is a problem and prevalent not just in adults or not just in children, but in adults as well, that those rates are high and have continued to increase. So whereas about 20% of children have obesity, about 42% of adults in the United States have obesity. And this is obviously a significant public health issue. But I thought this was interesting. We all know that this is a problem here in the United States, but it turns out worldwide, these rates have also continued to increase. And in fact, in some countries in the Middle East, including Iraq, Saudi Arabia, and Egypt, rates are almost as high as they are here in the United States. In some populations, greater than 40% of the adults have obesity. So this is going to be continued to be an issue that we need to address on a worldwide scale. And then as far as we care about this from a clinical perspective, these are all of the diseases and all of the different body systems that are affected by obesity. So at the CDTR and specifically the HIDR core, we've adopted sort of a broad perspective of diseases that are affected by diabetes and obesity. So if we think about these as all kind of cardiometabolic diseases, you can see that there's really not very many systems in the body that aren't in some way influenced by this. And the reason that this is a concern with adolescent obesity is we're starting to see the onset of these diseases at much younger ages. So specifically type 2 diabetes and metabolic associated liver disease, hypertension, we're starting to see in younger ages, which means that they've had the disease for longer. So we're starting to see the complications of those diseases for longer. So this is another reason, besides just preventing adult obesity, that we want to try to address obesity in adolescents. But we also know that obesity is a complex disease. So I'm going to talk a lot about health behavior change at the individual level. But there's sort of a paradigm shift that's happening in medicine where we're realizing that there's a lot of systems that contribute to obesity, some of which are completely outside of our patient's control. So really, they may only be able to influence their individual activity and their food consumption. So you can see that there's all these other factors. There's biology, there's food production, there's societal influences that are all contributing in this obesogenic environment to push our patients towards obesity. So while these health behaviors are important, there's absolutely a role to things like medications and bariatric weight loss surgery and other things. When we've sort of optimized these things, the patients have done all that they can. There's also a role for environmental changes and health policy changes. We as a society need to have a healthier environment and not just put all of kind of the onerous behavior change requirements on just the individual. But that said, I'm going to focus now on mobile health applications or mHealth apps as one potential tool to try to help guide all of those changes. So we know that there's a huge market for mHealth apps and that it's continuing to grow. So of the 3.4 billion global smartphone users out there, about 50% have at some point downloaded at least one mobile health or mHealth app. Which has resulted in pretty significant profits. So there's an estimated $57 billion of revenue in fiscal year 2022, which was about 87 million mHealth users. And this is anticipated to grow to about $236 billion by 2026. So huge opportunities for market growth and commercial development, as well as sort of these health benefits that I've talked about. And we know that there's a lot of advantages to using mHealth for these interventions for children and adolescents. The studies have showed that kids and adolescents really like mHealth apps because it can deliver this content, text, sound, gamification, animations that can really help sustain the user's attention during your study and long enough to try to make these health behavior and weight changes. It also aligns well with their technology preferences. So they're on their screens anyway for more than 2 hours a day. So let's harness that for good. Teens also like it because of the ease of use. It's right there in their palm. They also like it because it's customizable. So it empowers the user for goal setting, data tracking, and social networking, which has its pros and cons as we'll talk about, but really seems to appeal to this population. And as researchers, we really like it because of the wide socio-demographic audience. So about 95% of adolescents in the US have access to or own their own smartphones or tablets. So this isn't something where we have to worry about them not having access to it. 95% of these teens have access to it. And a big concern for me and my research team as we were developing CommitFit, we wanted to make sure that we weren't going to make these health disparities worse. So we did a lot of research onto this and found that there really are no differences by ethnicity or race of these mHealth and smartphone uses. And there also, fortunately, are no significant differences based on socioeconomic status. Really, 93% of teens who live in households with incomes less than 30,000 also have smartphones. So that seems like it could be a potential barrier, but the studies have found that it's really not, that even these low-income families have access to smartphones. But there are some disadvantages that we really wanted to focus on. And a major one for our group and for our studies is this rural digital divide. We know that smartphone use and access to broadband wireless is lower in these rural populations. Now, there's some legislation that's coming out that's supposed to be helping that, and we have seen some improvement in this, but we do know that there is still a divide that exists. We're also concerned about risk of cyberbullying, and we're aware of these harms that have come out about social media. So as we're designing these mHealth apps, it's really important to make sure that we're intentionally putting safeguards in to not risk the self-esteem and eating disorders and things like that from social media and these mHealth apps. And I'll talk about that a little bit when we talk about development of CommitFit. We also know that so far, mHealth apps are not currently commonly being used by children and teens very often. There was a study in 2016 that only about 21% of adolescents had ever downloaded an mHealth app, and only about 8% of them used them regularly. There was another study that about 27% use fitness or nutrition apps or both. So some variance there, but we can see that there's still lots of potential to increase the use of currently commercially available mHealth apps. And the reason that we think that teens aren't using these regularly right now is lack of awareness of available apps, the lack of quality of apps that are out there, and also just sort of this app fatigue, right? So there can be so many apps available, it's hard to pick out exactly what the good quality apps are. And we also know that a lot of these mHealth apps that are being used by teens weren't really designed for teens. They're designed for adults and aren't based on evidence or clinical practice guidelines. So that's another deficit that we really wanted to address with our app. So for the apps that are out there, what are they based on? What are the health behaviors and the behavior change theory that they're rooted in? So most of them target nutrition, physical activity, and screen time, which is kind of ironic if you think about it, because we are potentially increasing screen time. But the behavior change theory, and I put this in there specifically for our research team because he does a good job of making sure that we're grounded in theory. So this is for you, Mihai, was that most of these are based on self-determination as well as social cognitive theory, with the overall goal to support and strengthen users' self-regulation capacity. So some of these are based in these theories, but really only about half of the studies have included a behavioral change theory. And then the behavior change technique that are usually incorporated in these mHealth apps are goal setting, self-monitoring behavior, feedback on behavior, prompts and cues, rewards, and social support. And you'll see we try to incorporate all of these in our CommitFit app. Another theory that's used a lot in these apps is this idea of gamification. And I really like this. I think this can be really motivating, especially for these adolescents using our apps. But gamification is just this idea of using game design elements in non-game contests. So for mHealth apps, usually you're going to see points, leaderboards, badges, and challenges to really try to motivate these health behavior changes. And the studies have shown that these can be successful to engage teen and adolescent users to both stick with the app as well as make these health behavior changes. We've also seen gamification used in different contexts, sometimes in business as well as education and classrooms as well. So I think we're going to see a lot more gamification in the future. But the question may come up, do these mHealth apps actually work? Can they be used to reduce weight in children and adolescents? And the studies out there are a little bit mixed, but overall point towards kind of a promising trend. So the first major study that I could find was this Chen 2017 study, which showed that mHealth apps can be used to reduce BMI in adolescents at 6 months. And then there was a systematic review that came out in 2021 of mobile apps for weight management in children and adolescents. This included 9 studies and over 900 participants. And of those studies, about 3 of them showed improvement in weight, 2 of them showed improvement in BMI, and 1 showed a decrease in body weight, and 1 showed improvement in physical activity, including step count. But the other 5 studies showed no improvement. So like I said, kind of a mixed bag. A lot of heterogeneity in the studies out there. And then most recently, there was a 2024 systematic review and meta-analysis by Wang that showed that there is potential, but they said there was a small to large beneficial effect on physical activity, sedentary behavior, BMI, agility, and muscle strength in children and adolescents. So once again, kind of a mixed review, but the meta-analysis on BMI specifically showed a mean weight difference of about 0.31 kilograms per meter squared reduction in BMI that was clinically and statistically significant. So the evidence suggests that there may be potential to use these mHealth apps to reduce weight. A big question that we get, though, is why did we not just use some of these products that are already available? Why did we feel the need to develop CommitFit to do our own mHealth app? And the real reason that we found that the currently commercially available mHealth apps fail is, first of all, they don't include the adults and adolescent together as a team. And we see that as a huge deficit and something that's very different about our app CommitFit. They don't use gamification sufficiently, and they weren't really developed by medical experts or based on clinical practice guidelines or evidence-based. So I highlighted just 3 of the common mHealth apps that are out there. The first one, Curbo, from WW, formerly known as Weight Watchers, was really sort of our guide of what we didn't want to do with our app. And because it was specifically a weight loss app for children, it got really just terrible reviews. It was not developed with medical experts, and it was criticized by parents, physicians, the American Academy of Pediatrics, due to the concern that it could increase eating disorders. And actually, the last time I checked, it was actually taken off of the Apple market because of the concern of this. It's based on sort of the stoplight method, but it really encourages sort of calorie restriction and dieting and things like that. And that's really just not the approach that we have with children and adolescents to achieve a healthy weight. We really try to focus on positive health behavior goals like eating fruits and vegetables and increasing physical activity, and not really restricting what they're eating or calorie counting or things like that. 2 other apps that you may have heard about is Lose It. This is an adult app, not really developed with medical experts, also doesn't really use that team-based approach, as well as CommitFit, once again, not developed by medical experts, not explicitly adolescent targeted. It doesn't have a lot of gamification, and it isn't for that adolescent adult team. So this is our app. We're calling it CommitFit. It was developed by MU health experts by adolescents for adolescents and really uses gamification. So we used focus groups with teens and their caregivers, as well as providers. And then we did task analysis with teens after they used the app for 10 weeks with 10 interviews to really hone in on our design and development using user-centered approach. And then I'll show it uses gamification techniques and really engages the adult caregiver and the adolescent together as a team. This is just kind of an overview of our stages of development. So we were initially funded by the Triumph Award and then received Coulter funding for further development and evaluation of this. But you can see that we started with just very basic pen and paper, kind of sketching out our ideas and design, and just went through a lot of iterations. For those of you that have developed software or mHealth apps, you know that there is a painstaking process that is involved with lots of feedback from your end users to make sure you're doing everything in a very logical, user-centered process to make sure that the flow makes sense and that they're going to be able to use your app. And this is just kind of a deeper dive into our user-centered iterative changes. And you can see kind of some of the design changes that happen throughout the course of this. We were fortunate to have a great computer graphics research assistant, Taylor Bosworth, who's now an MD PhD student. So we were fortunate to have her skill and expertise. We did a lot of work with our adolescents to make sure that the colors and the design really appealed to them. They wanted it to be something that was visually appealing, but not too cartoonish or not too kiddish. So we really wanted to make sure we kind of hit that nail on the head. Now I'm just going to go over our app briefly to kind of show you kind of what we're doing with it. So this is just the login screen. And then we have a welcome screen. Congratulations on taking the first step. This is the dashboard. So they can set goals, they can log their goals. There's the leaderboard, resources, and then they can review their goals as well. And then this is the first step is to choose their goal. So the 5 health behaviors that we're focusing on are eat more fruits and vegetables, increase water intake, decrease sugary beverage intake, increase exercise or physical activity, and increase overnight sleep. And the reason we chose these 5 goals is we wanted to find the health behaviors that had the most evidence to really reduce and achieve a healthy weight in these kids. So we really picked the most evidence-based health behaviors. And as I mentioned, really not focusing on, we don't have them log their weight. We don't even really have them weigh themselves or restrict calories. We just want to promote these 5 healthy behaviors. So the first thing we ask them to do is tell us how long they want to work on the goal. And initially we ask them to just do 1 or 2 weeks, but after that they can work on the goal for 3 or 4 weeks. And then we want to know their current level. So how many fruits and vegetables do you currently eat? And then the app is designed to make a SMART goal. So it's just 2 levels above the current goal. So if they say that they're eating 1 serving of fruit and vegetable per day, the app's going to recommend that they choose a goal of 3 levels. They're not required to choose this, so they can choose for themselves what they want those levels to be. But we just wanted to provide some guidance of where CommitFit recommends they set those levels. And then this just kind of reviews the goal and how long they chose to work on it. They can also change the goal or delete the goal within the first 24 hours. After that, they're kind of locked in because we don't want them changing the levels or the goal throughout their goal period. And then every day they receive a prompt first in the morning about their goal and then the afternoon to log their goal. So just how many fruits and vegetables did you eat today? And then if they achieved their goal, they get 2 points. If they logged their goal but didn't achieve it, they receive just 1 point. But we wanted to incentivize the logging of the health behaviors, even if they didn't achieve their actual goal. And then at the end of their period, if they just logged consistently through that period, they get 6 points. And if they achieve their goal on average during that time, they get 10 points. So that's how we're trying to incentivize continuing to achieve and log those goals. This is the leaderboard team, so they can create teams. And in the study that I'm going to talk about, we created teams of the adolescent and the caregiver as a unit. But in the future, we'd like friends to be able to form their own teams, families, you know, lots of potential for healthy competition there. And these are our different leaderboards. So there's the global leaderboard that has everybody, and then the friends and family, which is more of the teams leaderboard. And this is the global one. So we wanted total points to incentivize people to continue to use that app, but then we also wanted to make it competitive for new users as well. So every week this leaderboard restarts, and this is the points per week to incentivize those new users as well. And then this is the team leaderboard. And this is actually averaged by the number of team members. So there's not an advantage for the larger team. We just want to incentivize per team member to log those points. And then this is my favorite feature of the app. This is our gear store. And we really spent a lot of time with the adolescents to develop this. So they have avatars. They can change the skin color, the hair textures. We tried to include it as much racial and ethnic diversity as possible. They can change the clothing on their avatars. And you can see on there, the CommitFit coin is right below where he's standing. So for every point they earn, they also earn a CommitFit coin, and they use that to unlock gear on the store. So this avatar, for example, has a cell phone. He had to use 10 CommitFit coins in order to earn that cell phone. So just kind of another way to try to incentivize logging and goal achievement within the app. We also have the goal progress on here daily, and for the past week and for the past month, their progress towards those goals. And then these are the resources. And we've actually developed more resources, some specifically targeting the parents and caregivers in the app. So more about how to partner with your teen to set and achieve these goals, and positive parenting and things like that. But here's just an example of one of those resources. So carbohydrates provide fuel for athletes by producing the glucose needed for sports activities, including running. Healthy carbohydrates include whole grains, vegetables, fruits, milk, and yogurt. So just information that we thought might be useful to adolescents setting these health behavior goals. And then I included this because this is a health informatics talk. This probably means more to some of you than it does to me. This is our entity relationship diagram. And it really shows, it seems like a pretty simple, straightforward app, but there's a lot of moving parts and communication that has to happen within the app. So we partnered with Dr. Zhu and his graduate students in computer engineering, and they were very great to work with. They were very responsive to all of our needs and the multiple iterations. So much appreciation to that group. So this is the pilot study, which we just completed not too long ago. It was completed at the South Providence Clinic, where I practice family medicine. And we had 30 dyads. So there were 3 arms for the adolescent. So 10 in the control group that just had their normal routine care. They actually were waitlisted, so they had access to CommitFit at the end of the study. And then 10 CommitFit intervention teams that use the app just as I described it. And then for 10 of those, we added an extra financial incentive. And that was 5 cents for each point that they earned in the app. And the purpose of that was to see if adding this extra incentive could really increase their logging and their use of the app during the 3 months of the active intervention period. We also included 30 caregivers, but we didn't give that financial incentive to the adults. It was just to the teens. So 10 control and 20 adult caregivers just used the intervention, although they were paired in the same group otherwise as their adolescents, so they could use that app together. And for this pilot study, because our goal was just to see if we could get people to use the app and use it for 3 months, and then there was a 4-month kind of follow-up period without that incentive, we included adolescents and caregivers of all weights. So you'll see most of them had a healthy weight at baseline. So we didn't really expect to see significant BMI changes. It was mostly just about using the app itself. And we provided $50 e-gift cards at baseline, 3 and 4 months. And then because the app was only programmed on iOS devices, we did have a loaner iPad available for families that didn't have access to an iPhone or iPad. And we did loan out several of those during the course of the study, which were then returned to us at that 4-month clinic follow-up visit. So these are our outcome measures, the things that we were assessing with this study. We did have this app use analytics, so software program within the app itself that really reported how often they logged, what goals they achieved, what resources they used, things like that. We also did the surveys of the health behavior, and I'll talk about some of the results and pros and cons to that approach, but those 5 CommitFit health behaviors, we surveyed those monthly. We also, at the clinic visit, obtained biometrics. So we obtained height, weight, and blood pressure for both the caregiver and the adolescent at baseline 3 months and 4 months. And then we had some just other surveys. We also had them complete some mental health surveys around anxiety, self-assessment, and some of these behavioral economics concepts, as well as just specific to the use of CommitFit and some commercialization price point data really relevant to our Coulter application. So these are some of the results from that pilot study. And this is what was most exciting to me, is that CommitFit BE or CommitFit money group that we gave that extra 5 cents for each point they logged, we really saw a major difference both in how often they logged and how often they achieved their goal. So I don't know if you guys can see here, the CommitFit BE is that incentivized group. 57% of them logged on every day that they could, compared to only 41% in the CommitFit group in the adolescents. And 47.4% achieved the goals that they set for themselves, compared to only 29% in the CommitFit group. And because there was so much logging, the p-values were very significant for those differences. I don't know about you guys, but when I see a p-value that low, I get very excited. So very excited to see those results. And then what was also interesting is that even though we didn't pay the caregivers, those that were in the group where their adolescent was being paid had a significant increase of their logging and goal achievement as well. 50% in the CommitFit caregiver group compared to only 31% in the CommitFit group, and achieved their the percent logging, and 36% in the CommitFit caregiver compared to 21.9% of the CommitFit group achieved the percent logging goal. So very significant difference for that as well, even though we weren't actually paying those caregivers. So I just think that that's really interesting, and we're onto something with the financial incentives, which we want to build on for our next proposal. This chart just kind of shows over time. So this is both the caregivers and adolescents together, but you can see at the differences over time. First of all, that the CommitFit BE group is much higher than the CommitFit group, but that also we only paid them at 3 months. We didn't pay them for that last 4 months, and you can see in that green line how that declines. So definitely, even just offering that 5 cents per point resulted in a much higher percent logging data. So that's pretty interesting to me. And then I mentioned that we did surveys of those 5 health behaviors. And we actually ended up doing an internal validity study comparing, so the self-reported at each of those monthly surveys that we sent out or did in person, and compared that to what the adolescents and caregivers were actually logging in their chart. And it turns out that there's not a very good correlation, that people grossly overestimate their health behaviors in these kind of recalled survey health behavior data. So we're still trying to figure out what exactly to do with these results, but we did see a positive trend of everything except for exercise. For whatever reason, the control group just had better exercise reporting than the CommitFit groups. But you can see that specifically, and this is a small sample size, keep in mind that we only had 30 dyads, and that water intake, even with a small sample size, was statistically significant at 60, 90, and 120 days with the combined intervention compared to the control group. So we do think that there's something here, but once again, this data should be taken with a grain of salt. The other thing we did with the health behavior data was just combine them together and just see, is there an improvement in these health behavior scores for adolescents and caregivers with the different CommitFit arms. And if you combine the CommitFit and CommitFit BE groups and compare that to control, at 60 days, we did see a statistically significant improvement in those 5 health behavior goals overall. And then specifically, I think this is interesting, CommitFit BE had much better scores than the CommitFit or the control arm at 90 days, which remember is when we finished those incentives. So there seems to be something going on in kind of the later use of the app. They self-reporting their behaviors have improved. And as I mentioned, because our sample side had a healthy weight at baseline, we didn't really see that much improvement in either the adolescent or the caregiver BMI. This is specifically for the adolescents, but it was similar for the caregivers. You can see that most of the controlled had a healthy weight at baseline, as well as the CommitFit and the CommitFit BE arm. So we really didn't expect, and we didn't really see a significant change in the BMI. What we did see a change in that I thought was interesting was the correlation. So we wanted to see if adolescents that logged more, was there a correlation to caregivers that logged more? And we did see that with this analysis. So you can see along the x-axis, we have the high logging, moderate logging, and low logging caregivers. And then in the blue is the high logging adolescents, purple is moderate logging, and the green is low logging adolescents. So there was a positive correlation between the caregivers and adolescents, both high logging or moderate or low logging together. That row value was 0.65 with a p-value of 0.002. So it was statistically significant. So where do we want to go from here? So that was the feasibility RCT that I just described for you. We are in the process of resubmitting an NIDDK small R01 that in addition to those financial incentives adds a lottery incentive. So for the caregivers and adolescents who have logged 4 out of 7 days at 3 months and 6 months, we're going to actually add an extra incentive. So in addition to that 5 cents per point, they'll be entered into a lottery where they can earn between $20 and $100. And this is really fits into this kind of behavioral economics theory that you can really try to motivate these health behavior changes, that some people are really motivated by these lotteries, even though their chance of winning is actually less. It can be a very motivating thing to try to sustain these health behavior change. So that's what we're trying to assess with this next phase. And we're also, instead of just looking at behavior change, initially we were going to look at BMI percentile in kids and BMI in adults, but we're actually going to do a more sensitive measure using DEXA that looks at the percent total body fat. So we think that that's going to be sensitive to some of these changes. We're still trying to figure out exactly our sample size, but we think it's going to be between 50 and 70 dyads. And then it's going to be a little bit longer study. So it's going to be at 3 and 6 months. And all of the adolescents and caregivers are going to have overweight or obesity at baseline. So we expect to see changes that we didn't necessarily see with the feasibility study. And then another major change is this is all going to be in low income Medicaid adolescents. So this is a population, as I mentioned, huge problems with obesity, and really one we want to try to design an mHealth intervention that can really address this population. So I'm going to pause there and just see if anybody has any questions about CommitFit or mHealth apps before I go on into our EHR tool.
This is Simões Eduardo. Thank you for a great presentation, very well developed process for the app itself, and then the whole design of the study, a pilot, and then this prediction, what we're going to do in the future is pretty obvious that you need to go for an R1 at small size and then maybe one that's larger to expand. But there are some questions here, mostly for one individual, Dr. Popescu. The first question he asked when he will present early on is that are teens aware of their health? How can we increase this awareness? This might be the key to better future health. So that was early in the presentation when you were showing the development of the app and everything. Do you want to comment on that?
So what's the question? Mihai, who was aware of the?
So my question was to take this thing in a bigger context. So instead of just hitting diabetes like kind of like some consequences, you go to a health awareness a little bit higher than that. And then I think this links to my second comment saying, you know, you have we have you have a you monitor somebody, you know, you have his data, and you say, hey, if you are continuing on this path, you might have, you know, 1 pound gain next, you know, next month or something. So, I
Yeah,
mean, my theory is that, uh, and again, I think I talked to you about that. People are, if you just give them some immediate problems, that they are aware of, they are rational and they do something. But if you say, yeah, yeah, you know, when you're gonna be 60, you're gonna have a problem. Who
yeah.
cares?
Yeah. And I think we'll get into that when I talk about the EHR tool and that role for AI.
Right.
Yeah, because I
That's
think you're
correct.
right. Like,
So,
I think the direct like feedback to providers and as like timely as that can be, as soon as they set these goals and putting in their logging, like could there be an opportunity within the mHealth apps to say, if you increase your fruits and vegetables to 4 per day, you would lose this much weight or something like that. So there's
right,
lots
right. And
of
that would be
potential for that.
personalized based on we can train models on the EHR, and we would have a model somewhat that we apply for the individual that is somewhat reasonable.
Yep,
So yeah. And then
absolutely.
that would be like if you having the connection with the EMR, that would be another thing where you could pitch as I don't think anybody's doing that. I mean, it's like to tell you, well, if you do the, I mean, I remember Zweig was telling me, you know, do what you do, you are good.
Not
So I
very
think that
specific direction.
again, I mean, that's one thing, but say, hey, if you do this, it's not gonna be good.
Right, right.
I mean, it's not
That's actually a
you
perfect
quantify it.
segue because so we have patients collecting all this great data within CommitFit, right? So we were thinking the next step is we really want providers in clinic to be able to harness this data. So if
Right,
they're
right, right.
collecting it, can't this feed into an EHR tool and then that specific feedback happening sort of with the provider and with the family of, oh, look, you logged that you had this many fruits and vegetables and you lost this much weight. So it's that sort of like direct feedback that is really sort of the motivating factor behind these EHR tools. So we did a lot of development with the families as well as with healthcare providers to develop. This is our wireframe for the CommitFit EHR tool. In addition to the CommitFit behaviors you can see on top there, we really wanted to hone in on what specific data from the EHR would providers want to see in a dashboard like this. So the surveys and focus groups told us that they wanted their last lab results, the vital signs, and specifically the blood pressure in children, the percentile is really important. Their current weight, they really wanted that in pounds, and then their BMI percentile for kids was really important. And then, as I mentioned, they want to be able to graph this against their weight over time. So this is the wireframe that we developed from that. This is our mixed methods study, the childhood obesity EHR development study. As I mentioned, focus groups with family medicine, pediatrics, and some health psychologists. And then we did thematic analysis, which I'll show you here in a second. And then we did electronic questionnaires that were emailed to providers who provide pediatric obesity care. So we had completion rate of 52 questionnaires for that. Initially, we just did family medicine and pediatrics here at MU, but then to get a bigger sample size and more generalizable results, we also included providers at St. Louis University, Children's Mercy in Kansas City, St. Francis, which is down in the Boot Hill, and then just the NAPCRG Research Forum as well. And here are the results. So this was just a study that we published with the results of this. Clinician needs for EHR, pediatric and adolescent weight management tools, a mixed method study. And I just wanted to highlight the study because Dr. Samoas and the HIDR helped provide some APC funds to help get this study published. So we're very appreciative of the support for that. And these are the focus group themes, and I really think that this is applicable outside of just child obesity tools. I think this can be applied to a lot of EHR tools, but the providers really wanted these tools to improve their clinical efficiency. They wanted to support patient and family shared decision making, so ways to have these conversations with family members. They wanted to improve patient continuity between visits. As I mentioned, some of these visits we're only doing once or twice a year, so how can we increase the reach of these recommendations in between those times? And then this is probably honestly the most important theme, and one that I feel intimately as a provider, it really has to reduce documentation burdens. We know that burnout is so high among physicians right now that any EHR tool needs to really work to reduce that and not add to any documentation burden. Another really interesting point that we found from the study is that we were concerned that clinicians may not trust the patient's logged data, but it turns out that they really trust this data entered real time over patient recall data. And I told you about that study we did. It turns out recall health behavior is really not that good. So patient log data that flows into the EHR is likely to be more accurate than just asking patients how many fruits or vegetables do you usually eat, or how much physical activity do you normally get.
Amy, you're gonna continue on this item, or because I have all the questions in the chat.
Oh, I'm sorry, I wasn't able to see that. Let's see. I think I might. Is it okay if I finish, and then I think there'll be time to do the rest of it?
Sure. Go ahead.
Does that sound good? Okay. So I'll go quickly because I do want to hear from the chat. It's weird. I can't see the comments or the.
I'll read it for you. Don't worry about it. I'm paying attention to the chat. That's why I'm doing
it. Okay, so I just wanted to mention kind of the next steps with this tool. So we wanted to combine this tool wireframe and develop this clinical decision support. So there's already this Smart on Fire curbside app out there that incorporates all of the clinical practice guidelines for child obesity from the AAP. There were very comprehensive guidelines that came out in 2024, and this pretty slick tool that already exists. We want to integrate these two together and have a tool that both displays this data and makes recommendations based on these clinical practice guidelines. And then, for the health informaticists out there, I hope you're not rolling your eyes at me, but we want to add AI to this. And this is really getting to what Mihai, I think, was talking about. We want to apply machine learning strategies to generate recommendations based on clinical practice guideline, EHR data, and patient log data to really optimize this obesity management and prevention. So in the future, when we develop this tool, we can make recommendations based on specific diet changes, activity changes, maybe even medications and things like that about how much weight loss they can expect based on their
right.
own.
And I think the patient feedback is the immediate feedback is like burning. If you put your hand on something and hurts you, you don't do it. But somebody tells you, oh, in some years it's gonna happen something, something diffuse, you don't know. But if you have constant feedback that what you're doing, I think that and that links to the like there is in the literature saying, oh, people don't use health devices, they use 2 months. Yes, if they don't have a burning problem, the problem is not
see the
really
benefit right away.
right. So if the problem is somewhere in the future, like obesity, or yeah, sure,
Right. And so we also want to expand this to adults. So this is a tool we're going to develop for kids first, and then also develop it for adults. And based on my search in the literature, this really isn't being done right now. Really, most of the EHR tools are used to kind of alert clinicians to overweight and obesity and maybe predict risk of obesity or chronic diseases in the future. There's really not any tools out there right now that are doing this. But I wanted to mention this study because I think it's really interesting talking about the role of AI with mHealth apps. And it really was pretty hopeful that there is a role to assist both individuals and healthcare professionals in prevention and management of chronic disease, and it can be done in a patient-centered manner. But some of the challenges that I think are really important to think about: data privacy and security, quality assessment, and then especially for AI, the reproducibility and uncertainty of AI results. So I think, at least for the short term, these need to be filtered through healthcare providers, because we don't want to put recommendations out there that are generated by AI that really just are either unsafe or don't make any sense. This is why it makes sense to do through a clinical decision support tool. It can be partnered with the provider and the patient to make these recommendations. We also need standardized methods to measure clinical outcomes with the mHealth apps, as well as techniques to encourage user engagement and behavior changes in the long term. So that's where behavioral economics, these financial incentives, things like that can be incorporated to try to encourage that.
So Amy, there are a few more questions.
Okay. Yeah, why don't we go to the questions, and then if I have time, I'll go over those.
So I'll leave my question for the end if we have time. But Jennifer had a question: why 3